Good morning. It's great to see all of you again, many of you again from the last 3 meetings, and I had the pleasure to actually attend all of them. So I hope that you'll find this informative. I've chosen to update some of the studies you've seen many times before that were presented at San Antonio this past month in December, and also just to do some overview in general about chemotherapy. As you know, many of you have been doing this a long time. It's really been exciting for us who treat breast cancer patients. And I've been doing it about 25 years now. And when I started, we just basically had adriamycin and CMF. And as you can see on this ladder, and you know from your own practice, we've gone from no chemotherapy and lots of patients having recurrences to using the CMF, having a benefit of about 4%, and then the 80s, the anthracyclines, a benefit of another 4%. Then the exciting era of the taxanes in 2000 with about a 5% improvement. And then finally, most recently, the most recent breakthrough was using trastuzumab or Herceptin with probably the biggest benefit we've seen overall. So over the last 20 to 30 years, we've seen about a 15 to 20% improvement in outcome in our patients with early breast cancer. And that's very satisfying, I know, to many of us, but we do have some ways to go. And as Wolfgang mentioned, we've been using a lot of old tools in the past, and we're going to talk about that more today. But the really important thing is we're looking at our newer trials and incorporating some of the molecular markers and the biology much more than we have ever done so before. So chemotherapy continues to improve outcomes and does still, and I think always will, play a leading role in treatment because obviously breast cancer is very sensitive to chemotherapy. Now I wanted to start just by showing you the latest taxane meta-analysis. This was for docetaxel presented at San Antonio. Now there have been several meta-analyses, as you know, looking at taxanes versus not, paclitaxel, docetaxel, and all have shown a benefit overall. And this is the latest one with over 20,000 patients and follow-up for the most part for 5 years. It's with or without docetaxel. And as you can see here, looking at disease-free and overall survival, in the bottom part overall, there was clearly a benefit when you added docetaxel to these regimens. And it was very clear in patients with node-positive disease, much less so in node-negative in this meta-analysis. And if you looked at it even more closely by subgroups, those patients that were younger, that were older, that had hormone receptor negative or positive disease, HER2 receptor negative or positive, all benefited when you added a taxane. The only group that really didn't seem to clearly from this meta-analysis was the node negative, but it was only 4,000 patients, and it may be because there were not enough events, because we've seen taxanes do benefit even in node-negative disease and some of the other meta-analyses. I wanted to mention the PAXO-1 study because I know many of you use the AC followed by docetaxel regimen, and this was just updated at San Antonio last month for 8-year follow-up, and it's the 6 effect versus 3 effect followed by docetaxel. And the 8-year follow-up is shown here, which was still very significant with about a 4% absolute benefit in disease-free survival, and also a benefit in overall survival. It's about a 5% benefit. So this, I think, is very satisfying to see this, that the data still held up after it's been published 3 years ago and presented again. Now, has the maximum potential of chemotherapy been reached? I think that's a big question that we all ask, and I think probably so, but I'm going to go through some of the studies that have shown incremental benefits in our current trials, looking at some questions such as concurrent treatment versus sequential, longer treatments, the number of cycles of treatment, and which agent should be used. Now, if you look at the update from that actually Wolfgang and I gave last year, not this past year, but a year ago at San Antonio, looking at BCIRG 005, which is 4 of AC followed by 4 of docetaxel versus TAC. And then my study, the NSABP B30, which was, again, 4 AC followed by docetaxel 4 versus the 4 of AT or 4 of TAC. We actually presented these back to back. And the BCIRG 005 showed absolutely no difference at all. And the B30 showed a benefit with the AC followed by docetaxel compared to the other 2 arms. And that was disease-free survival, and the same is true for overall survival. And though it's not shown here with B30, I also showed that those patients who achieved amenorrhea, and we had 2,500 premenopausal women, those patients who achieved amenorrhea actually had a better survival than those who did not, which I think is a very important finding in the study. For years, I think the rest of the world, Europe, has paid more attention to hormonal treatment, including ovarian ablation, whereas in the U.S. we have not done, I think, our job in that area. And this study clearly shows that amenorrhea is associated with an improved outcome. Now, the safety are shown here for the 2 studies, and just to mention that Dr. Eierman submitted his study to JCO and mine to New England Journal, so hopefully you'll be seeing them published soon. The febrile neutropenia rate with 6 of TAC without growth factors was about 18%, so it was higher than the 4 AC followed by 4 docetaxel. And in the B30, we had a 22% rate, so it was higher with the 4 of the Taxotere and the 4 of TAC, 16%, and that is with growth factor. So you still do get a substantial number of patients that have febrile neutropenia, even when you're using growth factors. Some of the other interesting findings are the low incidence of heart failure. It's less than 1% in both of the studies. And then most of the patients actually were able to complete the cycles, even those who got the 4 of the 100 per meter squared of Taxotere, as shown on the bottom. On the left side, 91%, and then in the B30, it was 86%. So that's a pretty substantial number of patients that were able to complete that treatment. And this is just to summarize the issue of the number of cycles, and I know it's a question we're going to talk about in my group when we talk about some of the cases, is how many cycles to give. When you look at the BCIRG 005, you had 6 of TAC, 001, which compared the FAC to the TAC. You also had 6, and that was beneficial, as you know, over FAC. And then in my study, the TAC was inferior because it was only 4 cycles. So really the conclusion is you at least need 6 cycles of TAC or chemotherapy for these patients. Now, the big 298 study was also updated at San Antonio this past month, and this is a very complicated study with 4 arms, 2 control arms, A followed by, CMF, or AC followed by CMF, and both of those are 7 cycles of treatment, versus a sequential treatment of adriamycin, Taxotere, CMF, and that's 9 cycles of treatment with 100 of the Taxotere, versus the AT followed by CMF. So very complicated study in node-positive breast cancer, and these are the updated results showing that essentially the AT, the sequential regimen, had the best outcome, but it was not a hugely increased benefit. So really there were little meaningful differences in this study, but the differences may result from combining and sequencing. And as I said, the sequence here is what had the best outcome, though it wasn't highly significant. So how do these results impact the role of chemotherapy and Taxotere in particular? I think that agents do matter. We all know that docetaxel is one of the most active chemotherapy agents, and it's been confirmed by the meta-analysis that I showed you. The delivery matters. We need to at least give 6 cycles of TAC, but I really believe that we've reached the glass ceiling of the maximum potential of chemotherapy in the unselected group. I think we've done enough of these large trials, thousands of women on these trials, and all of us who are in the business of designing trials want to change that and really look at more specific selected group of patients. And I know Martine's going to talk quite a bit about that in her talk. So what is the potential of chemotherapy? What do we know now in selected populations? Because I think we need to really learn from what we have now. If you look at age, for example, and that's been something, it's an interesting phenomena to me that not very many older women actually get put on clinical trials. And to me, it's an age discrimination. I think there's enough data through the years, certainly with the International Breast Cancer Study Group, showing that women who are older who have ER-negative tumors benefit from chemotherapy. We have that data, but for some reason, many physicians are reluctant to put those patients on trial. If you look at the U.S. Oncology trial comparing TC to AC, Dr. Jones presented this last year, I think it was, and it's been published most recently in JCO. And he broke it down into the different ages, as you see on the right. So the younger women, both, and the older women benefited from TC versus AC. So the message here is